lab this week, we are going to discuss muscle energy techniques. So I know in the past 2 weeks when we talked about P&L stretching, that is technically a subset of the METs. So with these videos and lab this week, we're going to focus on a different subset. So the two that I alluded to in the lecture videos include the isometric contraction with the post-isometric relaxation of the agonist muscle group. And then the other subset is the isometric contraction with the reciprocal inhibition, where you are activating the antagonist muscle group. So the first is going to be the soleus and the gastroc complex. So first thing I'm going to do is assess Cole's motion. So I want to see if I can passively bring him into 90 degrees of ankle dorsiflexion. If he is unable to get there with my assistance, then he would be a good candidate for muscle energy technique. For the purpose of these videos, I'm just going to be showing the post-isometric contraction component of MET, but in lab this week we can also practice the reciprocal inhibition. So the first thing you need to do is bring them into a passive maximal stretch. You can even apply some distraction on the talus, pulling just straight inferior and then pushing him into passive dorsiflexion. I'm going to take him off a couple of degrees and then ask him to submaximally push into plantar flexion. So I typically say between 20 to 25% of their max. So go ahead and push. He's going to hold between 7 to 10 seconds. You can hold a little bit longer, into 15 if you'd like. Good, and then just relax. And then you just push him back into passive dorsiflexion, or that passive stretch. And you can do this between 3 to 5 times or more if they need it. Next we have the Iliopsoas. So I'm going to have Cole come all the way off the edge of the table. He's going to fall backwards, grabbing one of his knees. Good. And all the way back. So remember, this is the Thomas test, where we are looking for hip mobility. So when I'm looking at the patient straight on, I'm looking to see if the knee is slightly extended, which would indicate a tight rectus femoris. If he is abducted, or if he is brought out laterally, that would indicate a tight TFL. Or if his hip was above the level of his ASIS, so if it was more into hip flexion, that would obviously indicate a potential tight iliopsoas. So what I'm going to do is I'm going to stabilize his hands over his knees, and I'm just going to push downwards. What you can also do is bring him slightly into internal rotation. And what I'm going to ask him to do is he's going to flex his knee up towards the sky while also externally rotating his hips. So he's going to shift his hip this way. Does that make sense? Okay. So again, I'm going to take him off a little bit, and then I want him to slightly contract. Go ahead and go. Good. And I'm using the side of my leg to prevent him from going into full external rotation. Holding for 10 seconds, go ahead and relax. And then you push him further into that passive stretch. Next we have the rectus femoris, so go ahead and lay on your belly, so all the way back. So for this, we will assess his range of motion. If he is unable to get his heel to his butt, that may indicate that he would benefit from MET. So I'm going to stabilize his sacrum, so my fingers are pointed up towards his head. I'm just using my thenar eminence and my hypothenar eminence to stabilize the sacrum. And then I'm just pushing him into that passive stretch for the rec fem. I'm going to ease off slightly, ask him to gently kick into my hand. Again, holding for about 10 seconds. Good, go ahead and relax. And then just pushing him further into that passive stretch, while also making sure to stabilize the sacrum. Good, go ahead and relax. Next we have the TFL, so go ahead and lay on your back. Good. So if I wanted to test his right leg, I'm going to bend his left leg up and over here. Good. Can you hold this position? Good. I'm going to stabilize his ASIS, and I'm going to bring him into hip adduction, so towards his midline. The patient should feel a stretch along their TFL or the lateral side of the hip. Next, I'm going to ask Cole, after taking off a couple degrees from the stretch, he's going to try to abduct his hip, so out towards his side. Go ahead and push. Good, relax. Once he's relaxed, I'm just pushing him further into that passive stretch. Again, remember you can do this up to 3 to 5 times. Next, we have the adductor muscle group. So remember, those are the groin musculature. I'm going to have Cole bend his leg slightly. Good, just like that. And I'm going to stabilize contralateral ASIS and bring him into hip abduction, which he does not have a lot of. Typically, you want to see a patient at about 90 degrees of hip abduction, and he's at about 45 degrees. So I'm going to ease off a little bit. Go ahead and relax. Good. And I want you to gently bring your knee towards your other knee. So pull in. Good. Holding for 10 seconds. Good. Go ahead and relax. And then I'm just going to gently bring him out to the side. You could also do it with a straight leg and then bring him out, but just make sure that you are stabilizing that other side. Next, we have the piriformis stretch. So I'm going to go ahead and have you, you're actually going to stay like that. So remember, the piriformis is a hip external rotator. So I'm going to bring him into hip flexion and internally rotate him to stretch the external rotators. I'm stabilizing his distal ankle and I'm pushing him internally using my right hand. I'm going to ease off slightly and ask him to externally rotate or push the outside of his knee into my hand. Good. Good, and relax. And then again, pushing him into internal rotation. Another way that you could go about this is have the patient cross their leg over, just like the TFL test. If they are unable to get into this position, or if they, like for example, if they have their heel up towards the sky in this regard, then that may indicate that they have a tight piriformis, so they would also benefit from MET. I'm going to stabilize the contralateral hip, and I'm just going to push him slightly into internal rotation, stretching the piriformis. I'm going to ease off a couple degrees and then ask him to gently push against my hand. Good, so he's going into hip external rotation, activating his piriformis. Again, about 20 to 25% of his maximum strength. And then go ahead and relax. Good. If they have any radiating symptoms, that may indicate that the sciatic nerve is getting pinched, so you want to make sure that you stop right away. Lastly, we have the hamstring. So it's broken up between the high hamstrings and the low hamstrings. So remember, high hamstrings, we would have the patient with their leg fully extended. It would be, somebody would need MET if they weren't able to get to 90 degrees like Cole, so if they're about 80 degrees or so, that would be a good candidate for this. Remember, I'm at his maximum passive stretch. I'm just going to ease off slightly, ask him to kick down into my hand. Isometric contraction of the agonist muscle group. Good, and then just relax. Just pushing it back into that next range of motion. For the lower hamstring fibers, you're going to bend the patient's knee. You're going to hold him in this position here. If they are unable to straighten their knee at about 90 degrees of hip flexion, this would indicate a need for MET. So I'm going to hold him here. Let's say this is his maximum stretch. Ease up a couple degrees and then ask him to kick his heel towards his butt. Good. Hold for about 10 seconds and then relax. And then stretching by extending his knee up towards the sky.